Case 6. A 45-year-old man with alcohol dependence presents with 2 weeks of productive cough and high fevers. So on the PA film, there is clearly a mass-like lesion apparent with an air fluid level. And here it is on the lateral film. Before we decide what it is, let's decide where exactly it is. At first glance, from the PA view, it appears to be in the right middle lobe, since the right middle lobe is adjacent to the right heart border. However, on the lateral view, the right middle lobe never reaches as posteriorly as this lesion is located. The right lower lobe is actually the correct location. So what is this right lower lobe lesion? Here's our list of cavitating lung lesions. Aside from the fact that the patient is an alcoholic and thus more prone to aspiration, there's nothing else that points to a specific diagnosis. Considering then just the most common, it is probably one of the top 4 on the list. So in summary, the patient has a cavitary lung lesion with an air fluid level in the right lower lobe, which is most likely due to pneumonia versus lung abscess versus tuberculosis versus a solitary lung metastasis. Case 7. A 55-year-old non-smoker with no significant past medical history presents with 2 months of progressive dyspnea. There's a diffuse lung process present, slightly more prominent on the patient's right side. Is this an alveolar process or an interstitial process? Here's a chart from Lesson 7 to help distinguish those two possibilities. The most helpful distinction in this film is this one. Are the margins sharp or hazy? And these opacities, relatively speaking, are sharply defined, particularly when compared to the ARDS example in Case 3. If you recall, interstitial opacities are usually further subdivided into reticular opacities if there are too many lines, nodular opacities if there are too many dots, and reticulonodular opacities if there are too many of both. In this case, it seems to be a predominantly reticular pattern. Here's the differential diagnosis of predominantly reticular interstitial opacities. This patient has a slight subpleural predominance of the opacities, which mostly suggests idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, and rheumatoid arthritis-associated interstitial lung disease. Since there is no mention of a history or exam findings suggestive of RA, either IPF or hypersensitivity pneumonitis are the most likely diagnoses. Finally, there is a slightly widened mediastinum. A normal mediastinum should be less than 8 cm in width, though this number is not accurate when the patient is rotated, as this one appears to be. So we can't be sure of whether the mediastinum is truly wide, although this area right here and its inferior extension looks a little suspicious for an aortic aneurysm or just a tortuous aorta, though this could be an artifact from the rotation. So in summary, the primary findings are diffuse subpleural reticular opacities and a possible widened mediastinum. The impression is interstitial lung disease, most likely IPF or hypersensitivity pneumonitis, and a possibly widened mediastinum from either a tortuous aorta or mild aortic aneurysm. Case 8. A 74-year-old woman, status post a dual-chamber pacemaker implantation for sick sinus syndrome, who is now presenting with syncope. The first thing to notice here is that there is something fishy about the wires coming out of the generator, particularly this structure here. What is that? That is actually a fragment of the right ventricular lead, which seems to not be present along its usual course in the subclavian vein and SVC. But if we look down here, there's the lead coiled up in the right ventricle, and it may even be looping back through the tricuspid valve into the right atrium. It's kind of hard to tell. So what this woman has isn't just a simple lead fracture, where the lead retains its normal position, but instead the wire has migrated distally. It can probably be retrieved from here, but it will be very difficult. And since a broken pacing wire can't conduct signal, it's no surprise the patient is bradycardic and syncopizing. Case 9. A 45-year-old man with HIV presents with intermittent fevers and weight loss over 6 weeks. So there's obviously a diffuse bilateral process going on. Is it alveolar or interstitial? There are small, very well-defined, homogeneously spread opacities indicative of an interstitial process. Unlike case 7, in which there were too many lines, in this case there are too many dots. That is, the patient has a predominantly nodular interstitial pattern. The differential diagnosis is roughly subdivided based on the size of the nodules. In Lesson 7, I attempted to place an exact cutoff to the size that differentiates these two categories, but the more I think about it, it's probably too artificial to draw a specific line, and better to leave it more vague as to where the line is drawn between them. In this case, though, these nodules are small enough to be called micronodules, and the combination of their size and significant number would also make this consistent with a so-called miliary pattern. While there is more than one etiology of miliary interstitial opacities, for a patient with HIV presenting with a subacute to chronic febrile illness with cachexia, tuberculosis absolutely must be the primary consideration. Other considerations could include various fungal diseases depending upon the patient's geographic location and environmental exposures. Case 10. A 35-year-old woman with scleroderma presents with subacute progressive dyspnea on exertion. The first thing you noticed is that the lungs look pretty normal. It would be easy for someone in a real clinical setting to quickly say that the lungs are normal and disregard the rest of the film, which of course would be a huge mistake. Now, so far in this self-assessment, I haven't gone through the other chest x-rays systematically using the A through F system. This wasn't because I don't advocate for a systematic method, but was more out of the interest of time and because it would be a pretty darn boring video to hear someone else going through the 15 x-rays systematically, especially when the location of pathology is pretty evident with most. But in this case, the pathology is more subtle, so let's practice the system. First, how is the technical quality? There is no apparent rotation, the entire thorax is in the film, the contrast and exposure look good, and the lung volumes are normal, suggesting the patient's inspiratory effort was good. So then A is for airway. In this case, the trachea is midline and of normal caliber. The carinal angle looks normal. B is for bone. The overall shape of the thorax seems subjectively a little boxy in my opinion. In other words, the lungs are not as tapered at their apices as seems normal, but this doesn't actually mean anything and is probably a normal variant. The clavicles and ribs are unremarkable, but the patient seems to have that tiniest bit of lateral curvature to the spine known as scoliosis. C is for cardiac and mediastinal silhouette, including the hilum. In this case, while the heart itself looks okay, there's a little fullness to both hyla. What are the etiologies of hilar enlargement? These are the major causes: malignancy, various infections, sarcoidosis, silicosis, pulmonary hypertension, a pulmonary artery aneurysm, and a bronchogenic cyst. Which of these seem particularly likely in this 35-year-old woman with scleroderma? Well, for anyone not familiar with scleroderma, it is a systemic autoimmune disease presenting with some combination of skin changes, esophageal problems, a peripheral vascular problem called Raynaud's phenomenon, interstitial lung disease, and pulmonary hypertension. So in this patient with progressive dyspnea on exertion, pulmonary hypertension is almost certainly the cause of both the hilar fullness and her symptoms. And to appreciate how the central cardiovascular structures line up with the hilar fullness seen here, let me superimpose this image. If we continue with our systematic method, D is for diaphragm, which looks okay. E is for effusions and more generally the pleura. No pleural disease is evident here. And finally, F is for fields, which as stated in the beginning of this case's analysis, are normal. So in summary, the patient's primary finding is bilaterally enlarged hyla, probably due to pulmonary hypertension.